Welcome to the Bone and Joint Playbook with Dr. John Urse, where we explore an extensive range of orthopedic topics and insights. Our goal is to help you understand the available orthopedic options and treatments available, and hopefully give you some answers to questions you might have. We want to thank our following sponsors.
Ted's Authentic Greek Salad Dressing and Marinade. It's healthy, gluten-free, and delicious. You can find Ted's in Dayton, Ohio at Dorothy Lane Markets, Health Foods Unlimited, and Dots Markets. That's Ted's Authentic Greek Dressing and Marinade. Thanks, Ted.
We would also like to thank
Stifel's GWR Group combines more than 65 years of experience helping high net worth clients consolidate, coordinate, and simplify their wealth planning strategies. The group has access to a full suite of resources to serve all of your financial needs. Email gwrgroup@stifel.com or call 937-353-2863 to speak to Guy, Brad, or Jeff Richardson. Stifel, Nicholas & Company, Incorporated.
Dr. Urse, welcome back to part 2 of the Bobby Project on the Bone and Joint Playbook with Dr. John Urse. So before we get started, just to recap, Bobby's had knee issues since he was in high school. He's been suffering. He's going to walk in your door, and we're going to have a conversation about what Bobby's options might be. So take it away. What would you do if Bobby walked in your door?
Well, we're going to have to talk at some point about his options for care, and he's going to need a physical exam. He's going to need what are called weight-bearing x-rays.
Is that what this is?
These weight-bearing x-rays are done.
Put that back up there, yeah.
We can show those just for this audience that started this podcast first. They always go to the end of the spy novel and find out who did it.
That's right.
But Bobby's x-rays have two sides, an inside and outside part of the knee. We call that the medial and lateral side. One of his meniscus or cushions on the outside of the knee was probably trimmed at a young age. He lost some of the cushioning effect, so the space between the inside is much greater than the space on the outside of the knee. When the knee loses what's called the joint space, that causes joint space narrowing. That's an indirect sign of arthritis in the knee, and I would say that's a moderate amount of arthritis. So we would then say, what are the things that we would want to do? We would examine his knee for motion, for what's called stability. Does it wobble in a front, back, or side-to-side direction? How are his muscles around the knee? Good pulses, all the nerves. Check the back hip and the ankle. We always look at what's called a kinetic chain because everything's connected. Then we'd say, based on this, we would say, well, gosh, Bobby, if you were in your 70s, someday you may need a new knee because you've got some moderate arthritis.
Right.
When we look in to do lesser types of surgeries, we can't take a putty knife and add cartilage, which is the cushion between the bones. So a cartilage wear problem is much like a brake shoe pad problem on a car. Once you lose that, then things squeak and grind and hurt more. So what I would tell Bobby, my job is to say, here's what's wrong. You have moderate knee arthritis. There are two avenues of treatment. One is a cure, and that we would put to the side because the cure is a new knee someday. So a joint replacement would be a way to resurface the knee to where that cartilage doesn't rub.
But why wouldn't you do that now?
He would never want to do that at an early age if
Why?
he didn't have to, because we don't know how long it would last. Our job is to get him to age 90 with his body part. And, you know, a knee replacement in a young active person we don't know how long it'll last. 15 years, maybe 20 years.
Then you got to do it again.
Maybe longer. Then you have to have another surgery. Then you're increased risk of complications, infection. You know, we just want to put off what we can as long as we can. So there are times we do patients with bad hips, shoulders, or knees at a younger age when there's no other option. The joint is beat up or the patient can't walk, they can't sleep. His level of pain is minimal for the type of x-rays he has. He said at rest his pain is a 1 or 2 out of 10. Certain activities it goes up to 5 or 6 though. So we want to do something to help that. So if we say, we always know there's a cure, think of a cure as a new car. We know we can always get a new car, but
Right.
can't we keep this car running like the ones in Cuba that are still running?
Cuban cars
What
again.
can we do? Well, we can look at his weight. So Bobby's not overweight, so not an issue, but we had a podcast saying every pound you lose is 3 pounds of force that you decrease across your knee. and therefore 20 pounds less weight is 60 less pounds across your knee. So
Wow.
that's a great trade-off with your healthcare provider, or family doctor, whomever. 2, we look at his leg. He's a little bit knock-kneed, probably because that outside cartilage was trimmed and he lost the cushioning effect. I would put a inside heel wedge in his shoe that would help balance the knee better. I would also talk to him about perhaps what's called an offloader brace that pushes the knee away from a knock knee position for him to wear if he's going to walk in a field to watch a soccer game, climb the Appalachian Trail outside, be on uneven ground. That would help him golfing or doing outdoor activities if he was having that much of a difficulty.
Okay, so you don't think he needs that now?
I would offer it to him.
Sure.
I would say, hey, do you have trouble going up and down a hill on a golf green or going on a trail with your kids in the woods? If you said yes, then I would wear a little knee brace that supports the knee and lines it up better when you walk.
Have you tried that, Bobby?
And you would only need it if you felt you couldn't do those things. If you said, hey, I'm actually doing fine, then that's just another option in the control category. So controlling the problem isn't curing it. It's controlling it. So we're going to talk about therapy, strengthening his muscles. He's already done that. He knows that's helped him. We're talking about balancing his feet, maybe a brace for the knees. But the other thing is, what can we do in the joint to quiet down swelling and pain? And he's had his knee drained a few times from the blood or swelling,
right,
which feels better because you get the fluid out.
But what about cortisone shots, things like that?
So there's three or four types of injections we do. One is cortisone. Cortisone is a fast-acting steroid, and it has anti-inflammatory factors that help pain. I call them wedding bell blue shots. You've got a wedding next week in St. Louis, and you want to walk down the aisle and not limp, get a cortisone shot. You're going to feel great for a few months. People are going to think, you don't even have anything wrong, Aunt Betty. And actually, Betty's knee looks crappy, but it's going to feel better. Cortisone, though, has damaging effects to cartilage, so it isn't something you want to do over and over because it isn't healthy for the joint to begin with. And someday, I think we'll supplant that with better options.
So what about just so for the folks listening out there, if they had some issues with arthritis, what do they go to the store? What over-the-counter anti-inflammatory do you recommend?
Yeah, I recommend, if you need something short-term, you can take Motrin or Aleve or some of the short-term, what are called anti-inflammatories. Are called non-steroidal anti-inflammatories. They're pretty quick-acting. They're okay to take for a short period of time as long as you're not on blood thinners, as long as you don't have kidney problems, as long as you don't have a bleeding ulcer. You don't want to take those things because there are potentially problems in those patients. There are some natural, what are called safe alternatives. We've had a podcast on things like boswellia
he takes
and
that.
curcumin,
I think you take that, don't you?
And the fish oils, some of the what are called cartilage protective agents, glucosamine and chondroitin. So there's a whole wormhole we can go down with all those. But those are things that are safer alternatives because they don't affect your stomach or your kidneys,
right,
or certainly affect anybody who's on a blood thinner for atrial fib. If you're on Eliquis, you can't really take a lot of these anti-inflammatories.
So before we get to PRP, what about the gels?
Gel is another accepted treatment. Insurances cover it. Most insurances, some of the largest carriers in the United States, do not cover it. Gel is a lubricant. It's literally a viscous gel called hyaluronic acid.
And where do you stick that?
You just put it in the knee. The knee's a capsule. You just put it in the joint.
That crack, or you put it?
Yeah, there's an open. The knee is a capsule. It's like a sac. And when we put an injection in from any direction, it's like putting something in a water balloon. It's going inside without breaking the balloon.
Okay.
So it stays in the knee, and that's one thing when we talk about, what will we do to put a PRP injection in your knee? How do you know it's where it needs to be and how's it going to stay there? Well, we're going to talk about using an ultrasound to put it in the precise location, but also the sac or lining called the capsule of any joint holds fluid in that joint. That's why his knee swelled, because it's swelled with fluid or blood, and that actually shuts down your thigh muscle and makes the knee hard to bend and hurt. So, getting some of that inflammation down and decreasing that is one of the things we're going to talk about. The gel shots are approved, at least in the United States, for knees only, not other joints for some reason. They're not approved for hips or shoulders or ankles. But viscous gel injections replace some of the normal lubricant fluid the body loses with arthritis, much like I tell people like the Tin Man. We of course did a podcast on gel shots. But if you look at the Orthopedic Academy's recommendation for gel for knee arthritis, it's actually weak. It's poorly
So they don't like it.
recommended. They don't like it because it only works on 60% of people. It costs more than a PRP injection if you had to buy it yourself, and it only lasts 3 to 6 months. So your insurance will cover it every 6 months, and there's people that get a benefit from it. So we will talk to them about that option, and we'll say if you want to come in every 6 months and get 1, 3, or 5 gel shots, your insurance may cover that, and it's a viable treatment for a knee arthritic problem.
So let's get to the heart of this whole topic is really the PRP, which you've been a believer in this for a couple years, since I've known
Over 10
you.
years, yeah.
Yeah. And a lot of folks haven't embraced it as well as you have, but it's coming to the forefront where now more and more physicians in Europe especially are kind of thinking this
Well,
could be.
also, I mean, there's 1,800 articles on PRP now for knee arthritis, and there's unequivocal evidence that it's beneficial for decreasing pain and improving function. It's better than cortisone. It's better than gel. The reason there's a disparity in the medical community is that the studies are not all standardized. So when someone publishes a study where there isn't enough blood taken, and let's just talk a little bit about what we would say. I would say you have the option of cortisone, you have the option of gel. If it were my knee and you were my brother, I would tell you to get a PRP injection where it uses your own blood.
Yeah.
So it's called a biologic injection. And we would simply tell you to drink a lot of water that day. We draw some blood, just like you'd get it at the lab to get your potassium checked. We spin the blood in a spinner device to get the special layers. We want to get a high concentration of platelets, and a high enough concentration of platelets is in the 6 to 10 billion platelet range. It's a lot to get a good outcome. If you do a high concentration with a good, what's called double spin, you then get a great result. One injection is all you need. It should last 1 to 2 years, maybe longer, and nothing works on everybody. The downside is it is going to probably cost you a few nickels. The insurances don't always pay for it. They will someday when the evidence comes through or they realize how much cheaper it is than a surgery.
Right.
Our military is covered by an insurer called TRICARE in the United States, and military patients have their PRP paid for by the insurance that insures the military. We have a big Air Force base in Dayton called Wright Pat Air Force Base. PRP is approved for knee arthritis and for tennis elbow. We're going to talk about platelet-rich plasma for not just knees, but also for partial tendons, where you have tendonitis, inflammation of an elbow tendon. We talked about the Achilles tendon, some of the hip muscles called the glute tendons. Everybody's heard of the rotator cuff tendons. They're not all completely torn. Some are just partially torn. So there's applications for platelet-rich plasma in other parts of the body. Today we're focusing on Bobby's knee because that's what hurts him. So we would talk to him about what would he want to know as a patient about PRP before he goes down the road and says, well, I'm going to go talk to this guy advertising on the radio down the street. What would he ask them? I think we should tell our people that.
All right.
So what I would be thinking from that explanation, and I'm sure if I'm thinking it, some of the audience is thinking it as well, if my issue is bone on bone, and I understand the process of you're taking the blood, you're spinning the blood, and then putting it back into the body or into the knee. If my issue is bone on bone, what is this new improved blood doing about that? Is it just a reduction of pain?
It's a great question. First of all, it's not growing cartilage.
Right.
Okay, so nobody is going to ever tell you get cartilage growth from platelets. They do not occur.
So he asked me in part one some of the remedies. These memories are 10, 15 years old. At one point, I was on a cadaver list to add cartilage into my knee, which didn't go anywhere. I was on this list for an extended period of time, ended up not going through with it.
$15,000. It's called an ACI procedure. You take a piece of your cartilage, you can grow it in a lab, propagate the size of the cartilage, a second surgery replants it. Now, if you have one little hole in the cartilage of the end of the thigh bone, then that patch of cartilage is a great option. Does your insurance want to pay $15,000 for us to do it? Probably not. You can ask, but it might be a tough thing. But certainly that is an option for treatment, but it's not for what's called diffuse or a wide area of cartilage wear.
Okay.
The second thing you asked is why would it help the inflammation or pain? And the main thing platelets have, they have over 1,100 growth and anti-inflammatory factors. Those things cut down the swelling and pain, and they last a long time. So those are called GFs, or growth factors. And there's some associated with the blood vessels, some associated with the lining called the fibrocytes. Some are different types of growth factors. You don't need to know all the GFs. All you need to know is your platelets are loaded with them, and they're in your blood. So you should be asking, am I getting platelets from myself or from a bottle or some cure from some salesman that marketed to your office here? Number two, how many of these do I have to get? How many platelets are you going to get with the blood you draw? How much blood are you going to take from me to get whatever you're going to give me? And how much is it going to cost? And blah, blah, blah. Those are things that really separate good and bad platelet.
Are you able to answer some of those questions? Like, what does this cost in general? You don't have to give a specific number.
I'd say this costs you around $1,000, give or take a little bit in different parts of the country.
That doesn't seem like that much.
Yeah. I tell people you're going to spend $800 on your dog's nails, so spend $200 more on the knee, you're going to walk on the rest of your life. If you go buy, at least in the United States, if you go buy the gel shots and your insurance doesn't cover it, one of our biggest providers, Anthem and Blue Cross, doesn't pay for gel for knee arthritis. I mean, everybody does. Medicare does. Everybody does.
Yeah.
Anthem, biggest provider, go, we don't do it. Why? Well, it doesn't work very well. I wouldn't do it either. But if you decide to go buy it yourself, I'll put it in for you. You have to go get it. You're paying over $1,000 for that at the cheapest place you can find it. And some places charge $1,500, $1,800 for gel that's inferior to PRP.
So how long does it take for PRP to kick in and like me to feel happy?
Right away. People feel good right away.
Why?
Well, because of the anti-inflammatory and growth factors. Now, it takes time for some of these take a month or two to really kick in and feel really better. So we tell people a couple things. One, all PRP is not created equal. Two, the studies are all over the place because the amount of blood taken, the cell counts, the way the spin is done is all varied. And if you're getting a Kmart, and I hate to, Kmart's already in trouble anyway.
Blue light special.
But if you're getting a crappy PRP draw with a small amount of blood, 10 cc's of blood, and a crappy amount of platelets, like you could say, how many platelets are you going to get? And if they say, well, we're getting 1 billion, it's like, I need 10 billion. The numbers matter. And everything in science, when you look at the studies that are successful, higher cell counts of platelets, higher success rates. And crappy cell counts with crappy amounts of blood and crappy spins, single spin instead of a double spin, different ways to do it.
Right.
There's a reason your chili powder mix wins the cook-off, right? Because it's better.
He's actually good at it. Yeah.
It's in the ingredients and the technique. Therefore, when you do that, we have a thing called an ultrasound. We accurately place the injection in your knee.
Well, where would that
it would
go?
just go into the joint.
Just right there where that crack is.
Yeah, there's an opening there.
Okay.
And people get shots in the knee. Same place you get a cortisone shot. And you can, I always tell people, you can drive yourself in and drive yourself home that day. You're not under anesthesia. You're not zonked out. You wear a little knee sleeve. I like a little compression sleeve over the body part. Just any kind of compression is fine. Neoprene or whatever you got, cloth. I like people taking it easy. Motion's fine, but we're not going to do a lot of strenuous squatting and therapy things after that. And we use what are called outcome scores. So I would give Bobby just a questionnaire. He would fill it out before we do the PRP injection or what are called the bone marrow. We talked about bone marrow aspirations in other podcasts. That's where stem cells come from.
Right.
They are much stronger. They have 20 times the growth factors the platelets have. So if he had the means to pay for stem cells, which
how much different is that cost-wise?
4 times probably.
So
well,
it was 1,000
4
before.
to 8 based on if you go to LA, they give you a velour robe and a cocktail, and they call it a spa experience, and they charge you $8,000 for a stem cell injection. But they're drawing bone marrow from your pelvis, where you have a lot of what are called it's called a bone marrow concentrate.
Yeah.
Those have some potential for growth of cartilage. I'm not supposed to say that, but if you look at MRIs at people a year after bone marrow aspirates, they have some healing in cartilage. with bone marrow, not the PRP.
So is a stem cell, do you get the PRP when you do a stem cell? Is it like you get 2 for 1 in that one?
No, well, not most people would combine the PRP with the bone marrow concentrate.
Okay.
You also have to understand that bone marrow concentrates are not a primary indication in the United States for medical use. So that would be called off-label. So their indication for bone marrow is bone marrow transplants for blood diseases like leukemia. So this is a off-label application of a device, but we use medicines for different things because they help in other areas. They just happen to be originally used for a certain thing, and then they're used off-label for this. If you took gel and put it in your shoulder, it certainly wouldn't. It wouldn't hurt it. It's like a lubricant, like the Tin Man, right? But it's off-label to do that. So your surgeon might do it. He might say, "Oh, the FDA says I can't." It's like one hinge or the other hinge. Why can't you spray both? But somehow the gel is only approved for knees.
All right. So as we come to our end of this, is there anything that he, as a potential patient of this, should have asked that we didn't ask, or we just didn't have the time to ask?
I think he should do what all good patients and consumers do. Do your homework, see who you're seeing for your problem, and then you'll get some information from AI and artificial intelligence. You'll get information from the internet, but this is a marathon, okay? Our job to get him later into life with his body part. And if we can turn off pain generators and get him more functional, maybe modify his activity so he doesn't make things worse. There are things that are worse for shoulders when you do overhead exercises and you squeeze the rotator cuff. I mean, it's the wrong thing for the problem you have. So find out what's wrong, find out what your options are, and see what makes sense. He may say, I had a cousin who had a PRP injection and it didn't work. My first question would be, how much blood did they take? Had they spin it twice? Did they get enough of a platelet count? Did the doctor even tell them how many platelets they got? Your blood, all our blood has a certain amount of platelets. We want probably an 8 to 12 times concentration of platelets to get a good PRP outcome. If you do that, you only need to do it once. And then maybe in 2 or 3 years, he gets another PRP shot. To me, that's a home run. You're delaying a big surgery. You're kicking the can down the road while his kids are growing. He's still walking on the trails with his kids. Put a cookie in his shoe, get a little knee brace if he needs it. Some people don't need either of those. Keep his exercises going. Make sure he's not overweight. Try some cartilage protective agents. All those are safe things that are doing no harm. And there's no downside to PRP. It's your blood. It's your biology. So we talk about things that are useful and useless, and harmful and harmless. And we're going to do a podcast on just those two things, like what helps and what hurts, right? Like if it helps and it can also hurt you, then you should know that. Like your knee replacement can help you, but it's got some side effects if you get a blood clot or an infection or like every surgery has complications.
Yeah, that'd be a good podcast.
So that would be important to know. It's all risk reward. Gel shots have no downside to them. They either stop your door from squeaking and help your knee in the same vein, or they don't work. The problem is they just don't work on 40% of people, and that's a lot of unhappy people who are getting 3 shots. You're schlepping grandma in through 14 inches of snow in the winter 3 times in January, at least in North America, and now she's got an injection that doesn't help her knee. Grandma might need a PRP shot.
So, Bobby, we're wrapping this up due to time. Did you learn anything that you found useful today? Is there anything that you gleaned from this conversation that we all had here about this?
Yeah, absolutely. Just the education on PRP. I'm not the only one of my buddies that played sports at a young age and now have knee problems, and PRP gets thrown out a lot. And when it's just buddies talking without any type of medical background, some people just share what they've heard, good, bad, unsure if it's good for them. And you answered my main question about PRP, which is I was hearing a lot of upsides versus some of the other stuff we talked about and what the downside was.
They call it financial misery, but it's really, you have to ask people, what is the value? When you pay for braces for your teeth, the guy may charge you $2,000. You're like, that's a lot of money. It's like your teeth are crooked. Your kid's gonna grow up never dating girls with crooked teeth and never get a job. Like, you have to show people the value for what they're getting. Most people just need to get that information. I would also just tell you my website, drjohnurse.com, has all these pre and post procedure recommendations. There's lots of blog articles, podcasts. There's probably more than you want to spend. You know how long people spend on the website? We have that from analytics.
I bet it's probably less than a minute.
40 seconds.
Yeah,
that's the complex
but that's
understanding of that's every people
every
are.
website.
Yeah, they just
I do.
I got a little information. I don't want to know too much about Martha Washington. She was married to George. That's all I need.
All right, well, folks, thank you for joining us today on the second part.
Can I thank our sponsors?
You go for it.
Ted's salad dressing. It's a great Greek salad dressing and marinade. And also Stiefel GWR Group. They're great financial consultants. We appreciate their sponsorship. And, of course, Tri-Level Recordings for doing the podcast.
That's it, Tri-Level Recordings. All right, Bobby, we want to thank you for joining us on this two-part episode of the Bone and Joint Playbook with Dr. John Urse. Matter of fact, let's do this. If you decide to do this, and we're not putting any pressure on you, right? If down the road you decide to do this, we'd like to have you back maybe a few months after you've had it done.
Yeah, sure.
And to ask you some of the questions.
Yeah.
I think Tri-Level Recording should pay for that PRP injection. Well, you got a lot of sponsors on your shirt. Maybe you can talk to one of them.
Next. All right, folks. We'll see you later. Bye.